Euan, you've worked as Executive Director of EASO for almost 15 years. What are the key changes you've seen in obesity care, policy and advocacy over that time period across Europe? And what are the key challenges for the next 10 to 15 years?
I think it has been 15 years, which is a long time. So a lot has happened, but at the same time, a lot hasn't happened. So a few things I can highlight that are positive. So that would be certainly in the last year, there has been a greater recognition at the policy level that obesity is a priority. But I'm not sure if that's happened because of us or because COVID has given us that opportunity. And so I don't think it should have needed COVID to get us to this level of opportunity, but I think that's maybe where we are. One of the really positive things as well is that there is a much stronger patient voice now. I think across Europe, across the globe, in lots of individual countries, there are strong patient representative organizations who have been trained, who have been funded, who are well organized. And I think that's a very, very important change that's probably happened over the last 5 or 6 years, not over the last 15 years. I think there are more people working in the obesity space. I think there are more people in the medical arena who understand it better, but at the same time, we still struggle with a lack of education around obesity. I think in medical school across Europe, you're still only getting maybe 2 or 3 hours of obesity-specific education in the curricula. I think governments and policymakers still very much think about diet and exercise. They think much more about prevention than about treatment. They think that you can prevent very easily, despite the prevalence showing that 30% or more in most countries of people living with obesity. So I think there have been some positive changes, but also there have been frustrations that things haven't changed in some areas as well. And I think that shows that we have to fight in certain areas. I think really improved education of healthcare professionals, a much better understanding amongst policymakers, but also I think a much better understanding still in the general population, who I think still regard obesity as an individual responsibility issue. And there's a lot of stigma and discrimination still. So there have been positive changes in that time. There are more, let's say, medical organizations, medical companies involved, which helps, but I think there's still a lot of change needs to happen. But we're on the right track, but I think we still have a lot to do.
I agree with what Euan has said, and I think it's a sobering thought this week or this month, the number of people who died from COVID-19 over the last year, past 4,000. That's exactly the number that died from obesity-related complications every year in Ireland for the last 10 to 15 years. And that penny has dropped in the last couple of years with our health system, and the kind of education is absolutely key, and that is being acknowledged, and the building blocks are being put in place to introduce a Making Every Contact Count education module to all healthcare professionals around addressing the issue of weight appropriately, and for the first time ever, the HSE are putting in resources in the community, within the childhood setting, within the adult setting. 54 dietitians within the adult setting specifically to deliver weight management programs in the community. But if we don't have healthcare professionals identifying and raising the issue appropriately and signposting, well then they're not going to work. So it's absolutely key.
This year's European Obesity Policy Conference has the theme of addressing obesity, unlocking the key to resilient health systems. What do we mean by resilience, and what is needed to achieve this at a political, regional, European level?
Yeah, thanks. That's a tricky question, but I was hoping that we'd have that one after the policy conference, but I'll give it my best shot. But in this setting, resilience really means that a health system has the capacity to absorb shock and to be able to recover from crises. And so things like the Ebola and then COVID-19 have really made health systems and governments think about these things in a much more focused way. So how can a European or a national health system be structured in a prepared way so that it can cope better with these kind of crises? And I think a lot of the health systems coped okay within the European, at least the EU setting, but I think it also showed that there was a lot of work that still needed to be done. And actually they have developed things like the European Strategic Foresight Report, which is a report which looks at both the resilience of health systems, but also looks at the future shocks, future crises, and what if scenarios, so that it is looking to the future. And it's actually identified both obesity and cancer as two specifically listed NCDs that need special attention. But I also think that this political will is only one part of the issue. Political will is only one thing until you have a system in place that will address all the challenges that we have with obesity. So certainly at the European level, we would like to see every country having a very strong obesity action plan, a national strategy for obesity that goes way beyond obesity listed amongst other NCDs or as part of a diabetes plan, and that isn't focused primarily on prevention. So something that puts the patient at the centre, the person at the centre, that the system is built around that would include strong treatment, management, educational components to it. So I think that's what we need to see happening. But I think the fact that at least at the EU level, they are thinking about foresight, thinking about the future, making sure that the health systems can cope with these shocks, and perhaps also understanding that obesity was a big factor in COVID risk and in complications, etc. That will help us to put obesity perhaps at the forefront of thinking. But we're at the early stage of the development of or at least the implementation of the foresight report and the related process.
That there has been significant media attention recently following results from a trial of semaglutide and weight loss outcomes. Can you tell us your thoughts on this and other ongoing studies in the area of obesity medications, and perhaps touch on how we can work together to advocate for policy change for reimbursement of obesity medications, as is the case for other chronic diseases?
It's a very exciting time when it comes to obesity treatments. We now know that we can get half of people to lose 15% of their weight, and we can get a third of people to lose 20% of their weight with the new medications. And that's really only the beginning. There's a lot of new medications also in the pipeline. And when we're going to be able to combine these medications, we're going to be able to achieve 25, 30% weight loss, and same weight loss that we have with surgery at the moment. I think this is going to be foundation drugs. It's going to completely change how clinicians view obesity. And I think this is the opportunity for us to work together to drive this idea that obesity is a disease, and that obesity is a disease that needs treatment, chronic treatment. And I think with effective tools, we will be very successful.
And do you think the reimbursement will follow on or will we need to push it in some way, and how do we need to do that together?
Reimbursement is going to be a challenge, and I think it's this idea of shared value. How can we demonstrate to the payers and to governments and to clinicians and industry that treating obesity as a chronic disease is the right thing to do for all the stakeholders? So I think we need to get away from this them and us approach and try to work out where's the sweet spot. And at the moment, the problem that we have when it comes to reimbursement for obesity drugs is that the healthcare models don't consider weight loss as a so-called utility gain. And therefore, all the healthcare models is built around complications of obesity. Now, when we're going to get 25% weight loss, we're going to be able to reverse some of the complications of obesity. And I think that is going to be a game changer. So we need to be humble, and we need to have some sympathy with the payers and the regulators, but we have to work with them to try to get reimbursement as quickly as possible.
I wonder, Euan, are you aware, is there an example, a European country that has reimbursement?
So at the moment, the UK has decided to reimburse liraglutide 3 milligrams specifically for the prevention of type 2 diabetes. So that helps you to understand that it's actually to stop a complication. And I think that is the road that we're going to go down for some time in the future. But that's also important because that is where most of the money is spent on a healthcare budget, not on obesity, but on the complications of obesity.
What I would say is I think that whole question of reimbursement is going to be an important policy and advocacy challenge for us in the coming years. Given that health systems are under immense pressure, I think it's important for us to maintain that dialogue with policymakers and with health systems to really make sure that they prioritise obesity as a health specialty in its own right, and therefore think about reimbursement, because reimbursement is not available to very many people in the European region. Mm-hmm. And it's something that we have to fight for. And I think we have to make evidence-based, often economic arguments to make that point.
So I think, Carel, you said we need to be humble in our approach to the payers, and I agree with that, but I think there needs to be controlled anger also, and real clarity around the fact that obesity cannot be handicapped because it has never had treatment. Therefore, when you introduce treatment that has a cost, even if that cost is a penny, it's an increase. Mm-hmm. And we need to just make it very clear, as you say, that the ongoing treatment of the complications of obesity is like no other disease is dealt with. And that we now have to just roll back our thinking 30, 40 years and start treating the disease that we recognize it now is.
I completely agree. And I think that's why it can't only be a health economic argument. It has to be, patient advocacy, people asking, their TDs or their members of parliament, please help us. And that's been missing so far. And I think that's why the ICPO and the ECPO is doing such great work at the moment, because it's actually giving patients a voice. 24%, 25% of the population of Europe have this disease. That's a huge amount of people that could vote. So if we can combine the science, with people understanding that they deserve to be treated because they haven't done anything wrong, I think we can be very, very effective, provided that we have good treatments. And I think that is going to be the game changer if we can show that we can achieve and maintain 20-25% weight loss in the long term.
In July 2020, the European Commission and the European Centre for Disease Prevention and Control launched a plan of action on health preparedness for COVID-19 outbreaks with immediate effect. And for the first time, people with obesity have been formally listed as part of the category of medically vulnerable groups. We were wondering if you believe that COVID-19 may serve to place obesity as a higher priority for governments and funding bodies, and perhaps increase recognition of obesity as a chronic relapsing disease. And what can we do to ensure that this happens?
The data is very clear on this, that obesity is a very important disease that has complications, and also in the COVID era, it leads to increased death. So, but if we now don't kick on, if we don't use this very tragic fact to push forward and demand that there's more treatment, for people with obesity after COVID, we're going to lose this momentum. So it's not good enough for us to stand back. It's now using this opportunity to push forward and really drive this idea that obesity is a disease that needs chronic treatment like any other chronic disease.
I think there was a huge overwhelming positive when we realized that, we were seen as a medically vulnerable group due to COVID alongside other NCDs such as cancer and diabetes, and rightly so. And there is a silver lining with COVID, as much as we don't want to say it, because it has put obesity on the map for us. We're noticing there is more education, there is more people listening when obesity is, talked about. So there has been a silver lining. I suppose for us, when we think politically, we need to ensure that there is the alignment between the policy and the science, because, you know, we can advocate and we can tell our stories, and we've an incredibly empowered advocacy group across Europe. And I think the ICPO is testament to that in, you know, what they've achieved so far in such a short space of time. But we can do all of that work, but until the policymakers are actually listening to the science of obesity as a chronic disease, well then, you know, our efforts aren't going to make much of an impact. So it needs to be like, we have all have a shared responsibility. It needs to come in from every angle, and we're just happy that, you know, the patient voice has been listened to correctly, you know.
Thanks. Euan, you want to come in there?
I would say we still need to be quite vigilant in that respect as well, because one example would be France, where people with obesity were originally listed as those as members of that vulnerable group, but then they were taken off the list, and it took some fighting from the French patient organizations to get them back on the list, and they were able to use WHO definitions and classifications and some of the work that had been done at the European and the global level. But I think it showed that just because they had that initial list had included people with obesity, they were taken out in some countries. So I think we still need to make sure that we monitor what is happening and remain vigilant. And I think we still have to keep ensuring that we talk to policymakers regularly, because they change, they forget, they don't always remember what we're asking them to do, etc. So I think that was just a good example that we have to keep on top of this.
Yeah, that's great. Thanks, Euan. Grace.
Yeah, I think we have a real opportunity as well for those patients being discharged from hospital having experienced COVID-19, that we ensure that obesity treatment is part of their rehabilitation plan. So we know that WHO and internationally there's this push for rehab post-COVID, particularly around long COVID. But we need to make sure that those patients have access to obesity treatment as part of that, like they would be able to access antihypertensives or whatever they may need as part of their discharge plan. And I think that's a really kind of a way we can expedite this aim that we have. I'm not sure what's happening around Europe, but I think it's something for maybe EASO and indeed ASOI and everybody here who has influence to try and get that on the agenda as well.
Well, in Ireland, the Department of Health acknowledges that obesity is a disease, but we still haven't seen implementation of a chronic disease care model for obesity up until this point, or full acceptance of obesity as a disease among many health professionals in Ireland, as they would see other chronic diseases like diabetes and heart failure. And we're wondering, do you think this will change with publication and hopefully implementation of the model of care for obesity management in Ireland? And what else do we need to do to ensure that this happens?
I'm very optimistic that the change is now happening in terms of actually addressing obesity as a disease. And I would say the mood music changed I think about 2 years ago. There was an ASOI conference or study day, and you can tell me which one it was, but the first one where there were people living with obesity making statements in between the talks and as part of the talks and chairing the talks. And two very senior people came from the Department of Health, Stephanie O'Keefe and Sarah O'Brien. And they listened. And at the end of that conference, they said to me, "Oh my God, we have to get everyone saying obesity is a disease. It's unbelievable." And I was shocked at the impact of that morning of those two officials attending, because we've been saying it all along, but they haven't been hearing it. And the energy then that has come into generating a model of care, there is an appetite now for implementing that model of care already. So, you know, there's 5 levels of care. And 3 of those are already funded. The sharp end of treatment, which I think is really important, around drug therapy and bariatric surgery, it remains, we don't know. They're planning how to fund it. And I think because of COVID-19, it will get over the line. It's my hunch at the moment. You have to have a model of care because that's the way our system works. You have to have buy-in that it is treating a disease, and there is now that buy-in. And the continued effort has to be around advocacy, evaluation, showing that what we're doing is working. And then you will reduce the other complications of obesity, like your diabetes, like your cancer, like your obstructive sleep apnea. And you'll have two things. You'll have a model of care that's flowing, and it has to be, you have to be treating every level for it to flow. And you will have a reducing burden of disease. If that's ever achievable, but you will at least be mitigating the burden of disease as opposed to it just continuing to rise. So I think advocacy, number 1, 2, and 3, and then treating the disease, because then the message to prevent will be empowered no more than, the Stop Smoking grew out of treating lung cancer and heart disease. And it will be the same for obesity now that it is recognized as a disease.
And I might just come to Michael Crotty, if you don't mind, because I'm just thinking training is such a key part of recognition of obesity as a disease. Do you think there's an appetite for that kind of training within the primary care community?
Absolutely. And I think, I'd just reiterate exactly what Euan and Donal have said about kind of education and advocacy are huge. I think within primary care, I know the Irish College of General Practice has shown an appetite. I've spoken to them about education for GP trainees, continuing medical education for GPs around obesity, around the model of care that's coming around treating obesity as a chronic disease. So there's a huge appetite there, and it's in the planning stage at the moment as far as how exactly we kind of roll that out to GPs. But I think they're also hearing from their members about this deficit in knowledge maybe amongst GPs, that this is something that they want to be involved in. This is personally, obviously I'm biased being a general practitioner, but I think GPs are ideally placed to be involved in managing patients living with obesity. Just being generalists and looking at how much it affects patients in various different ways. So there's definitely an appetite, and there are wheels in motion about kind of instituting training and resources and making those available to GPs. Yeah,
just on the issue of advocacy, I think we have a bit of a conundrum, because we want to let the general public and everybody else understand obesity as a disease, but yet we're basing most of our evidence on body size. So I think we have to figure out a way of kind of, being razor sharp with our message about obesity being an accumulation of fat tissue that causes health problems rather than a certain shape or size. Particularly in childhood, I think this is going to become it's going to become a challenge to get the public on board if we're just talking about a shape or a size in relation to identifying obesity.
Just the perception there, Grace, you're saying about people identifying about obesity, but quite a lot of our patients would be reluctant to speak out because they feel that it's like we're looking for sympathy when you share your experiences, and that's what they feel, and it's quite hard to get advocates to speak out because they don't want anybody feeling sorry for them.
Yeah, I would just agree with that. I think we need to ensure that obesity is treated by policymakers just like any other NCD is, and that's the aim that we should try to achieve. But also we can continue to have advocacy training as well. So we've got some advocacy training coming up in the next few weeks via EASO, and I think a continuous effort to empower and train our advocates is going to be helpful, because we're always going to need to communicate with policymakers and the wider the wider public. And I think I would also argue that the more education that we develop within medical schools, within the general practice population, then the understanding around obesity as a disease will also improve. And I think that will be helpful too.
I was just going to add to that, like, I mean, for patients and for society as a whole, I think what needs to be done is we need to rethink and speak about obesity in different terms, as Bray said. Like, weight is a symptom of your obesity. You know, we need to shift the language and that narrative from weight to obesity and talking about the person's health, and stepping away from identifying the number and scale. That's going to take many, many years, because society is just fueled with that narrative of obesity is, you know, is your weight, and it's just visual and it's everything else that we hear. So one thing that Susie said there about, you know, the patient community, and they're a very sensitive and vulnerable community because they have been bullied for years, but seeing how empowered they become through, I suppose, aligning with the clinical and the scientific communities over the years and becoming empowered and educated, that's what's causing the shift. Like, when I look at ECPO and EASO, we've learned from some of the best scientists, researchers and clinicians that are pretty much in Europe. And that's how we've become empowered to share our voice in knowing the science. And when you speak out as a patient, and, you know, I suppose people living with obesity are generally deemed kind of lazy, sloppy, a little bit on the stupid side. And like, we all know this. When you speak out as a patient and you're articulate and you understand the science and you have a story to tell, that's where advocacy is at its prime, I feel.
So, Michael, in order to achieve significant progress with prevention and treatment of obesity, we need to have full engagement and agreement within primary care and among GPs in particular. What do you see as the necessary steps forward, and what are the potential barriers towards achieving this?
Like I said, there's an appetite in general practice, you know, to be involved. I think there's probably a deficit in education. Certainly during my training in general practice, there wasn't any focused training on, obesity as a chronic disease. I think, certainly education is a big area that needs addressing for GPs and GP trainees. I think that, teaching GPs, we do it for lots of other chronic diseases. We start conversations, we screen for problems, we open a dialogue, we listen to people and their stories. And obviously, again, I'm biased, but I think GPs are within lots of other kind of chronic diseases, we're very good at that. But we haven't focused that on the chronic disease of obesity. And a lot of GPs don't see this as their role, perhaps. They don't see, obesity as a medical problem. They don't see it as a chronic disease. And we need to educate them around that. Again, we need to educate them around person first language, and just how we talk about things. We need to, look at, how we can help GPs to implement kind of practical behavioral interventions, how we can get them comfortable with using, pharmacotherapy and medications that are available. Like I said before, GPs are generalists. We're used to treating diabetes and hypertension, cardiac disease, mental health issues, mechanical issues, osteoarthritis. We treat all of these issues. And, obviously not everybody who kind of, struggles with weight has all these problems, but some people do. And we treat those patients for these problems, but we just haven't addressed their chronic disease of obesity. So I think education is a huge thing. I think also Donal had mentioned the model of care. I think that would be very important to general practice, to have a referral pathway available, to have somewhere to go. Not what's the point, but it's very challenging to bring up a conversation about an issue and then for it to end there because we don't know where we can go with it. We can commiserate that this is, terrible that there isn't, treatment options and things available, funded for patients, but having a model of care where we can refer on to people who've got a specialist interest, where we can refer on to a multidisciplinary team, to people who are trained and interested and motivated and passionate at kind of treating this issue. So I think that's huge, having a referral pathway, knowing where we can go with it. I think also, recognizing obesity as a chronic disease for GPs will be very, very important as well, around resourcing and funding. We, as GPs, we do chronic disease management for heart failure, for asthma, for diabetes, and there's resources to that. And I think we can't forget about, obviously, when I say general practitioners, I also have to include, you know, GP practice nurses as well, because they're the backbone of every practice. You know, they hold things together. They do so much chronic disease management, you know, and put in a huge amount of effort and time. So it's also education for those kind of, you know, members of the team as well. So I think we do it for other chronic diseases. I think if we could apply that to the chronic disease of obesity, and for funding to follow that, because you know, we talk about kind of barriers that are there. You know, we mentioned about kind of weight bias and weight stigma, and you know, I think that's something that definitely GPs and probably across most healthcare practitioners we need to look at. We need to address our own opinions. We need to talk to our patients because of the internalized stigma that people feel as well. I think, you know, if we can kind of, you know, move past that weight bias and stigma and see that, you know, people are motivated, people are interested in health, that, you know, it isn't all about the numbers on the scale, it's about gaining health, it's about reducing the impact on people's life and improving quality of life. I think that'll be huge as well. So, you know, I think resourcing, I think education, I think also, you know, as far as in general practice, I think educating the general public is huge as well, because I'm a big believer of, you know, if people know that this is a chronic disease, if they know that this is not their fault, if they know that there is evidence-based, scientific, safe, effective treatments available, you know, they need to go to their GP to talk about this. If their GP isn't on that page yet, by heck they will be when somebody presents to their practice and says, makes an appointment, I want to talk about my weight. The GP will, you know, their heart will go crossways on them initially, and then they'll have to step away and say, okay, well, this is a deficit in my knowledge. This is something I need to do. And we do that in general practice all the time. You can't know everything about everything. So, you know, you have to go and there has to be resources available for people to, you know, educate themselves on what should I be doing? What is the evidence-based kind of treatment that's available, you know? So I think educating the public and people who are living with obesity is huge too, you know, to advocate and to present to their GP. Because again, you know, like we said, this is an extremely common problem that just at the moment, you know, in general practice, you know, obviously with COVID and everything, it's kind of a putting out fires kind of a service, you know, we're maybe not kind of focusing on some of these things, but as we move past COVID, you know, again, with some light being shone on this, you know, this is an opportunity to improve care, I think.
So in 2018, a member of the German Parliament and Committee for Health, who was responsible for diabetes and obesity, was invited to a plenary discussion with people living with obesity, a room filled with 300 patients stating their rights for treatment and reimbursement. Can you tell us a little bit about how patient advocacy brought about policy changes in Germany, Michael?
Politics is always a long road that never seems to end. It takes patience, a lot of patience. You need support from third parties, and you need patience. Yeah, it's often the case that patients are not taken so seriously. We took this action and we started a petition at the German Bundestag, and we also were able to win the specialist societies and professional associations as supporters, and some politicians as supporters for this petition. And hey, they've seen us. Yeah, they see, hey, there are patients that want to change something. This member of the German Bundestag was present at this event in the USA in 2080, I think. Yeah, it was Mr. Krause. And shortly afterwards, the German Obesity Alliance was founded. And this is the first association, yeah, where practitioners, politicians, the health industry, researchers, and also patients are represented, and they work together. It was the first time, yeah, and it's great. Currently, they're working on a disease management program for obesity. Maybe in 2 years, we have in Germany such a program for obesity. When you have a good community, I come back, you have a good base. Yeah? And with this base, you can do a good work, yeah, and have a good base and enough people, then you have votes for the politics.
It seems to us that ECPO has achieved a really central role in obesity work across Europe in a very short time frame. And I'm wondering, what do you think is driving that? And do you feel like you are making inroads into changing the obesity narrative?
To be honest, if you think of how ECPO kind of evolved, we came from a working group of EASO. We were a number of patients, and as it was rightly mentioned and has been taught of many times, you know, a lot of the time the patient can be there to tick a box. You know, we're seeing a lot of these fantastic incentives and projects across the globe, and one kind of box that needs to be ticked is, you know, is there a patient that sits on this advisory board or committee? And in many ways, I think in the beginning we kind of felt like that. We felt like, right, we're the elephant in the room, you must have us on board. But then when you actually realize that your voice at the table is listened to and makes changes in surveys and language and reports, and in how people speak to each other, and how clinicians are teaching and researchers are, you know, sharing their data, that's when, I suppose for us, we realized that we're not just, you know, the guinea pig here. We're not the elephant in the room, and actually the patient community is listened to by those that respect it. We're not a box to be ticked. And we, I suppose, went on to, I suppose, challenge ourselves and become a community of patients from across Europe that would work with the clinical and scientific community and have that as our backbone of support, and use our voices, which is kind of that emotional hook, because like, it's statistically impossible to not know somebody who has obesity. Like, everybody knows somebody. It's somebody in your family. And when you tell your story, and if you ask an MEP, you know, do you have anybody in your family that has obesity? And the whole room raises a hand, and you say, well, for the next 30 minutes, when I tell my story, I want you to put their face on my face. And that has an impact, because they suddenly realize that this isn't that they go to a job and they go home and they forget about it. This is somebody that they know that it impacts. I do this work and I go home after this work and I'll finish this call. I don't have a choice to unzip my obesity and take it off and be done with it. And that's what it is about being a patient. It's living with this disease and letting others know what it is like and why we need change, and identifying that the number on the scale is not what it's all about. It's about our health. Like, the amount of people that would actually say to some of our patients, gosh, you have great skin and hair and everything else. And you reply to them and say, that's because I take so many vitamins you would not believe. You know, we take the list of them. We look after ourselves. We were in it for our health. We're fighting this because we want to see our grandchildren growing up, and we want to be able to skydive like Susie at 80 years old. You know, and that's what this is about. It's about changing health for everybody. And like, when I look at the community that we've built up across Europe and what they stand for and why they're empowered because they're educated. They're empowered because they listen to people like yourselves that are on this meeting, that give them that backbone of support. They listen to your words and they take that and they interpret it into their own, and they use that, because I think what's happened over the years is we've had a disconnect in the language between the scientific clinical communities and the average person. The average person, you know, can't pronounce half the terminology you speak in an average roundtable meeting with your peers. So we take that messaging and we turn it into language that people understand, where they can share with their friends and their family, and they can start to open the conversation. And for us, that's really what advocacy has done. It's empowered people who are now educated to share their story, to make changes for their family members and their friends, and pretty much everyone across Europe. And it would seem to be catching and working.
How are we addressing the treatment of children and adolescents with obesity in Ireland at the moment? What are we doing well, but what can we do better?
I think we've definitely made progress. So I think when we initially were meeting to set up ASOI, it was probably 2004 or 2005, Donal. I think it was just yourself and myself on this call that were at that meeting. So we have definitely made progress. I think there's more of an interest in the area. There's definitely more empowerment of parents themselves coming forward. A lot of our patients that we see in CHI at Temple Street are from self-referrals to their GP to look for referral to paediatrics to then access our treatment. We've seen an increase in, I suppose, commitment to funding. So as Donal mentioned, I mean, the clinical program, I think, is a total game changer, really. And, you know, not only do we have somebody leading that who is genuinely really committed to this area, but is also, you know, an expert clinician scientist, which really helps leverage interest and commitment. So that's really, really important. And also, Donal has been, you know, very supportive of child health, which often you don't necessarily get from adult medicine because they're so separate. But I think for obviously any chronic disease or early onset obesity, you cannot look at these two things separately. I think, as Michael said, primary care, GPs, practice nurses, health and social care professionals, public health nurses working in the community have much more of an interest in this area now compared to maybe 5 years ago. And a piece of work that we're doing funded from Sláinte Care has had over 800 responses in terms of people identifying their needs for training. And that's helping us to design a really usable and practical training course for child and adolescent obesity so that we can really improve the baseline knowledge for qualified health professionals, but also students. And then I think we're improving a little bit around stigma and discrimination of these children and adolescents. I think COVID has brought about another understanding for the public at large, and something that we all speak about a lot in obesity prevention and treatment is inequality. And I think COVID-19 has let en masse the population understand how difficult it is to control weight, first of all, particularly if you have less you know, access to healthy food, if you don't have the resources to provide healthy food at home, if you don't have the resources for a child to play safely outside, if they don't have access to education or PE, as we've seen for many of school children working online, and then also the social contact. So the isolation that many adults and children and adolescents have felt, I think, has had such an impact on all of us, on our own health, that it helps us have a little taster of what it's like for some of our children and adolescents and families and adults with obesity, and how fine that kind of control, the homeostatic control of weight is, and when it goes beyond, when we start to gain weight and start to build adipose tissue, how challenging it can be to manage that, particularly if we don't have support or the resources we need. And so I think there is an improvement in the understanding. Community services, I think, are being built up a bit more, which is fantastic. We have a really pivotal moment on our hands in terms of the development of the National Children's Hospital and you know, really implementing the model of care in childhood and adolescent health. So hopefully we'll get better resourcing for our Tier 3 service and to develop a Tier 4 service, and then really properly lead out on integrated care, which I really believe, I mean, I'm more positive now than I've ever been about this. It's really, you know, it's very exciting that I think we're going to be able to really develop something fantastic together, and we're all working so well together that it's, you know, it's a really positive time. But still we see children, you know, adolescents being referred to us too late, so by maybe 15 and a half years, and children who have really high BMIs, and really, you know, one of the most important indicators for long-term health for a child or an adolescent is if they're in school and being educated, and many of our adolescents are dropping out of school because of their obesity, and I think that is something that's a real red flag that we have to get on top of, and that requires obviously obesity treatment, but in child and adolescents that's a much broader it's a much broader net of treatment. We need a lot more in terms of medical social work and family support, and linking in with social supports and child welfare, child protection issues. So but I think we're improving. I think we're getting there. I'm pretty excited.
Brilliant. Glad to hear you're positive, feeling positive.
At last.
I'll give the last word to Donal then. Donal, I saw your hand there. A brief last word.
You know, I just to say, I think the final piece in the jigsaw Grace alluded to there, and it is sláinte care. So sláinte care was introduced a couple of years as the whole of government framework, or the Department of Health framework for a shift left in delivery of care into the community, right care, right place, right time. And Laura McGahey, who heads up sláinte care, has really, over the last number of months, come down on obesity as, if you like, the final common pathway towards addressing chronic disease. She seems to have recognized that we were treating everything that obesity causes and not addressing or preventing a major root cause. And she has pulled together the stakeholders within health first to get their house in order, with a view to going out to the broader determinants within the environment and the other relevant departments. And she is now championing obesity treatment and prevention from the rooftops. And we've never had somebody within the Department of Health doing that. And it is incredibly welcome, but she is, you know, bringing things together so that we will address obesity together, which is the theme of the day. And she is planning quite a big announcement on World Obesity Day in relation to what the department is planning to do. So it is an exciting time like that we haven't had before.
Well, I'd just like to thank all our speakers this evening. Reflecting on the theme of addressing obesity together in Ireland, I feel that our advocacy movement really started to progress exponentially when we began to work with ICPO as well as ECPO, and with the ongoing support from our European colleagues. Listening to the speakers this evening, we know there is a lot of work to be done, but it feels more achievable if we're working together. And as a group together, our message and our voices are amplified.
Thanks, Jane. I think the same too. And I know ICPO were relatively new in that we incorporated only just during the summertime, but we have been working for a time before that, leading up to that. And quite often our work isn't seen when we're sitting on committees and working away in the background. And just to say like a huge thank you to all of our team, because all of our committee, and that they're all volunteers, everybody's given up their time, and same with the ASOI. And it's fantastic to see people giving up their time to this, to advocate. And definitely, I think today we can see that addressing obesity together is the way that's going to push things forward for better outcomes.